Gastrointestinal interventions contains a lot of intervention. We all know basic endoscopy and colonoscopy. Apart from that, we have double endoscopy, ERCP, endoscopic ultrasound, high resolution manometry, 24 pH metry, capsule endoscopy. So all these interventions we can do for diagnose as well as for the treatment of various GI disorders. Today I will be discussing some 4 case scenarios in which how these interventions made a big difference in the diagnosis as well as in the management. So first I will discuss about a case of a dysphagia. It's a 35-year-old female came with a history of intermittent dysphagia which were liquid food then solid for the past 3 years. History of regurgitations of food and weight loss for the past 3 years. On clinical examination, she had failure and her vitals are stable. So when we approach a case of dysphagia, there are two reasons can be there. It could be a benign condition or a malignant condition. From the history, we can come for a conclusion, whereas a malignant condition, usually it will be progressive and the duration will be very short and they have other symptoms like weight loss and all. But the benign condition, it will be static and the duration is also will be very long. So, and as well as we can differentiate dysphagia into mechanical as well as the neurological reason. For mechanical dysphagia, most of the time the dysphagia starts with the solid, but the neurological dysphagia usually starts with the liquids first. When we see our patient, this patient had initially had dysphagia towards liquid, then gradually progressed to solid food, and duration is also for the past 3 years. So from this we can come for a conclusion, she is having a benign cause of a dysphagia and probably it is due to a neurological condition. So most common neurological condition we have to think of. So what will be your next step? Whether we can go for a radiological investigation, endoscopy, variant swallow, manometer, CT scan. If you have all these options available with you, the best investigation will be an endoscopy because endoscopy will give you the diagnosis on the spot and if needed we can do intervention also. This patient had a dilated esophagus, like dilated esophagus with food stasis as well as the food stasis and multiple food residues also can be seen. So we did a Bayesian swallow. Bayesian swallow showed the typical rat tail appearance in the esophagus G junction. So this is a classical features of an achalasia cardia. So whenever we see a case of achalasia cardia, usually we'll stop at this level. We do endoscopy, we'll do Bayesian swallow. If it turns to be achalasia, we'll stop. But ideally, we should not stop at this level because we have to go for the confirmatory test, which is the high resolution manometry. So manometry is actually simpler than an endoscopy, in which we introduce a catheter and we assess the pressure in the G junction as well as in the esophagus. Why we have to do this manometry? Because there are ideally 3 types of achalasia are there: type 1, type 2, and type 3, and each type will have different prognosis as well as the management also can differ with each type. So to identify the type, we have to go for a high resolution manometry. When we do manometry, this patient had typical type 2 achalasia. As we can see here, this is more pressure in the G junction with full pan-initial pressurization. That's a typical for a type 2 achalasia. When we have a type 2 achalasia, so these are type 1, 2 and 3. Mostly type 2 achalasia is the earliest form of achalasia with a good prognosis. Whereas the type 1, which is a long-standing achalasia, they have a poor prognosis. So once we classify them into type 1, 2 or 3, what will be our next step? We can have endoscopic myotomy or a lap Hellers myotomy or a pneumatic balloon dilatation or a esophagectomy. We have to decide based upon these available options. So as a gastroenterologist, we always weigh in the options of what is available with us and what is the beneficial for the patient. So this is the pneumatic balloon dilatation, which is simpler, easier, like a one-day procedure in which we introduce a balloon across the G junction, and from there we'll inflate the balloon to a particular pressure like 10 millimeter of mercury. That will disrupt the muscle fibers in the G junction. That's how we disrupt the pressure zone in the G junction. So it's a simple take care procedure. Second one is the esophageal myotomy. Peroral is we call it a POEM procedure, in which it is a surgical procedure. It's just not like a simple balloon procedure. We dissect into the submucosa, we cut through the muscles in the G junction, and then we clip it on the submucosal layer. This is equal to Hellers myotomy, but it is done through endoscopically. And third is the commonly done Hellers myotomy, in which through laparoscopic approach, the muscle will be cut open from outer to inner layer, leaving alone the mucosa. And along with that, we used to do a partial fundoplication. So these are the common intervention treatment we can do for a patient of achalasia cardia. So when you will ask the patient to do, so this is the guideline. Whenever you see an achalasia patient, we have to term the patient to low surgical or high surgical risk based upon the comorbidity, age and all. So those who are high surgical risk, those they won't tolerate surgery. These patients we can offer injections like Botox injections or a medical management. Those who are surgical patients, among these three, we can offer LS myotomy, POEM, or a graded pneumatic balloon dilatation based upon the availability. But whenever we see a case of a type 2 achalasia with a good prognosis, laparoscopic LS myotomy weighs in more than a pneumatic balloon dilatation. Whenever we see a patient with failure of one procedure, we can always go for other procedure for the treatment of the achalasia cardia. So by typing the patient through different types, we can ask the patient to go for a LS myotomy or a POEM or a pneumatic balloon dilatation based upon the individual types. So for that, manometry plays an important role in diagnosis as well as in the medical management. So I'm going for the next case. This is a 50-year-old female. She had hypotension, hypothyroid, and antiplatelets are due to CAD. She had complaints of a black tarry stool on and off for the past 3 years. Almost received 5 blood transfusion. Who came with severe anemia, pallor, tachycardia, and all. Her basic initiation showed low hemoglobin of around 4 grams per deciliter with a significant low MCV, which is a significant iron deficiency. Perfusion also showed microscopic hyperchromic anemia. So whenever you see these kind of patients who have a chronic anemia, we have to be work up for the reason for iron deficiency. But replacing the iron and replacing the blood is very important. But we have to find the etiology also. For that we can have all these options. So we did the patient have endoscopy. The endoscopy is normal, which doesn't show any active bleeding, and there is no colonoscopy also. We saw only melanic stool rectocecum. We have not picked up any active bleeding spots. So we did a CT abdomen, which doesn't show any active contrast extravasation also. So this condition is called as the obscure GA bleed. So in any GA bleed, we classify them into overt. In overt GA bleed, usually the patient comes with the hematemesis or frank blood in stools, whereas the apical GA bleed usually comes with a history of anemia, and we don't have the exact symptom of a GA bleed. Whereas obscure GA bleed, when we will say, when we work up for the patient of a GA bleed, but we are not able to identify the etiology in the basic endoscopy, colonoscopy, or CT scan, we term them as a obscure GA bleed. So whenever we have an obscure GA bleed, the probable etiology will be in the small bowel or vascular lesion. For that, we used to do capsule endoscopy, RBC scintigraphy, enteroscopy, or a diagnostic laparoscopy based upon the availability of the investigation. So this is the pictures of a capsule endoscopy. We all know it's a small capsule which contains camera. When we swallow after bowel cleaning, it will take photographs throughout the intestine and it is transmitting to the receiver. When we see through the images, we can pick up many findings. So this is a case of a small bowel diverticuli like Meckel's diverticuli. This is a case of a small bowel angiodysplasia. This is a case of an IBD with multiple ulceration. This is a jejunal polyp in the jejunum. So these are images taken by the capsule endoscopy. So it will give us these are the reasons for bleeding, which is occult and obscure, but we are not able to find through routine endoscopy and colonoscopy. Next comes the RBC scintigraphy. It is just like an CT imaging, but we can pick up a small bleed. The main disadvantage of this investigation is it can pick up only the location, it cannot find the exact reason. When you do scintigraphy, it can pick up the bleeding is in the right upper quadrant near the jejunum or in the right lower quadrant like near the ileum. That's the report they can give, but they cannot pick up the exact etiology with the RBC scintigraphy. But we can identify the location. After that, we can go forward with the laparoscopy or an intraoperative enteroscopy to find the exact reason. So this is the enteroscopy picture. We are showing a Meckel's diverticulum. Through enteroscope, we can go up to ileum through mouth. So, but it's a time-taking procedure. We have several instruments like double balloon, single balloon, spiral enteroscope, but we can reach up to ileum through mouth. We have to find exact etiology, but it will act like a therapeutic intervention also. If we find a source of bleeding, we can stop the bleeding using injections or clips available. So it is one of the diagnostic as well as therapeutic intervention for an endoscope. So in this patient, we did a capsule endoscopy. It picked up a angiodysplasia in the jejunal region. Once we did a capsule endoscope, we did an enteroscopy for a therapeutic option. Through organ plasma photocoagulation, we just ablated the angiodysplasia lesion, which stopped the bleeding, which is causing her the long-term anemia. So this angiodysplasia can come recurrently. So this is another patient's report who had the same history of an occult GA bleed, and the technetium scan we did, it picked up somewhere bleeding near the left quadrant, probably some in the ileal region they mentioned. So this is a intraoperative picture. Video play one. Video இந்த play இருக்கு பாருங்க ஆப்ஷன் play ஆகுது வாங்க play tap shoot. So this is an intraoperative picture in which we can see a large hemangioma. So this is a large small bowel hemangioma from the ileal region which is causing the GA bleed. It was picked using the technetium scan. We did multiple endoscopy, colonoscopy, which was not able to pick any reason for the bleeding. And once we find it in the laparoscopy, we did a resection and anastomosis. After that, patient bleeding has completely stopped. So most common etiology for obscure GA bleed will be a vascular lesion. It could be an abnormal angiodysplasia or abnormal vasculature that comes around 70 to 80% of the reason. Other reasons like IBD, ulceration can come, itoenteric fistulas can come, hemobilia, hemosuccus pancreaticus, all these things can present like an obscure GA bleed. So coming to the third case, so this is a 35-year-old male. He came with a history of an abdomen pain, severe constant epigastric pain which is radiating back. Along with that, nausea, vomiting is also there. Patient had a history of a binging of alcohol for past 1 week. He had tachycardia, he had sweating and fever is also there. And on palpation, he had tenderness in almost all quarters of abdomen. So more in the epigastric region. So with the background of alcohol presenting like an abdomen pain, nausea, vomiting, the first possible diagnosis will be pancreatitis. So we did a lab initiation which showed elevated lipase, high WBC count, elevated liver enzymes. CT scan then showed acute necrotizing pancreatitis, and right upper corner ultrasound showed normal portal vein, normal cholecystitis. So the first initial management for pancreatitis is the fluid replacement. We kept the patient NPO, we give IV fluids, we give prophylactic antibiotic, which is very controversial in many times. We can give enteral feeding based upon the patient's pain and vomiting, and pain medication. Once the pain and symptoms settled, patient was improving and he was discharged at the initial week. After discharge, the patient came back on third week with the same complaint like fever, abdomen pain, worsening of food intake, again vomiting. So we repeated the CT. This time CT showed multiple necrotic collection infected with air pockets. So if you compare the symptoms, in the first week also the patient came with the same symptoms of abdomen pain, fever, vomiting, but in the third week also he came the same symptoms of abdomen pain, fever and vomiting. But the management will differ because in the pancreatitis, in the initial week, most of the time the pancreas will be very bulky. It can form a fluid collection or a necrotic collection. But over the course of the time, most of the time the collection will resolve. But after third or fourth week, sometimes it will become a necrotic collection like this and get infected. So once you see a necrotic collection which is causing the trouble in the third or fourth week, we have to go for treatment options. We cannot manage with antibiotics or IV fluids. We can have either endoscopic intervention, surgical drainage, or percutaneous drainage, or IV antibiotic. So this is the different fluid collection in different phases of pancreatitis. So this is the normal peripancreatic fluid collection which is non-infected or non-necrotizing. Over the course of time, this can develop into a large pseudocyst. Whereas in the initial presentation as a necrotic fluid collection, over the course of time, we can become a necrotic collection with the air pockets. So these two doesn't need any intervention. Just we can manage the IV fluid and IV antibiotic. When the patient comes with these two and symptoms, we have to go for interventions and management. So these are the endoscopic intervention we can do, surgical intervention we can do, and percutaneous intervention we can do. So I am focusing on the endoscopic intervention. We can do an endo ultrasound guided cystogastroscopy using an endo ultrasound or through endoscope. We can locate the cyst. We can puncture it through a needle. Once the cyst is coiled, we can put a stent, metal stent or a plastic stent, which drains out all the fluid into the stomach. So this is one of the intervention to clear the necrotic collection from the cyst. Similarly, we can use multiple plastic stent also, and through the stent we can go into the cyst cavity and we can clear all these necrotic debris. This is called a endoscopic cystogastroscopy with necrosectomy. So these procedures can be done only in a selected individuals in which the cyst wall is adequately mature and is very close to stomach. So these are the pros and cons of each procedure. Percutaneous drainage is actually minimally invasive, which contains lower cost, lower morbidity, but the patient has to be on a continuous drainage for more than 1 or 2 weeks. The risk of infection and pancreatic fistula is also there, and we can do only for a small cyst cavities. Endoscopic drainage is having good success rate, but the expertise is very minimal. Not all the places can do an EUS guided procedure. It is very costly investigation, costly procedure also, as well as it can be done only in a cyst which is very close to the stomach wall. We cannot do a cyst which is very far away from the stomach wall. Surgical drainage is the ultimate thing. Whenever this percutaneous or endoscopic drainage fails, we have to convert the patient for a surgical drainage. We have to clear the fluid as well as the infected collection. So coming to the fourth case, is the last case. So this is a common scenario we used to see in many OPD. Patient coming with a recurrent chest pain, burning sensation, discomfort more than 4 years. The patient is roaming everywhere, seeing multiple hospitals, multiple endoscopies. Whenever they take pantoprazole or esomeprazole, they will feel comfortable. Whenever they stop, they will again have symptoms. It is a common symptoms for many patients. So when this patient comes to OPD with recurrent belching and bloating, with all initiation done so many times, the most common reason will be a chronic GERD, which is actually the proper GERD. Patient is suffering from the symptoms, or it could be a functional dyspepsia, in which the patient is having the symptom but there is no actual reflex. So in this scenario, what is our next step? What we can do? Whether we can continue same medications, or we can ask them to see a psychiatrist for antipsychotics, or we can go for a surgical option or repeat endoscopy. So if you have these kind of patients, the next step, ideally, once they have exhausted all the options, it should be a 24-hour pH monitoring. So that is the ideal test. So it is the test to find the exactly whether the patient is having GERD or not, or it's a typical functional symptom, as well as it will also give us a clue whether the patient will improve with the surgery or not. So for the pH monitoring, what we will do, we will insert a catheter through the nose. We will keep the catheter in the G junction. It contains different sensors to assess the acid reflux. So we will leave this catheter 24 hours inside the patient, and we will ask them to do their daily routine activities. They can sleep, they can walk, they can eat whatever they want, they can have their food, they can have their medications. But whenever they have something, we have to ask them to record using this machine attached to the catheter. So once it is done, it will record for 24 hours. After the procedure, we will get a result like this. So this is a measures which is done in the over 24 hours. So we have two sensors. This is the esophagus, this is the stomach. So this is the pH 4, 7 and 10. So the stomach sensor is showing almost all the curves in the acidic pH. We expect a alkaline pH in the esophagus, but we can see multiple dip less than 4 many times. So these are times when patient is having food. So after food, the patient is having dip in the acidic fluid. Here also is coming down. So we can correlate whether the after food patient is having acidity is there or not. When the patient is having the symptoms of belching, or when the patient is having symptoms of GERD, we will ask them to press the button. When they are pressing the button, whether acid is definitely coming to esophagus or they are just pressing the button, we can find it out. So using this method for 24 hours, we can analyze the patient. So this will be the report given by the software. So you can see here the study is done almost for 24 hours. Patient was in supine, upright in the 20 hours. So you can see the longest reflex. It will record the reflex time, how much it is there, number of reflex episodes, how long the episode has happened. So all those things will be calculated, and you will get a score called D-Mister score, which is 24 for this patient. So this is one important score. So this D-Mister score is actually the gold standard for diagnosing GERD. It is using many variables. Many studies has done. A score of more than 14.72 is considered a positive for GERD. So any patient above 14, we can severe into mild, moderate and severe. So if they have a significant symptom, like this patient had around 24.52, so it's a significant GERD. It is not a functional symptom. we cannot say the patient doesn't have a functional symptom. She is suffering from GERD. So probably this patient can benefit by going through a fundoplication. If we do a fundoplication, the sphincter laxity can be counteracted, and with lifestyle changes and proper dietary management, this patient's symptom can be relieved. We cannot say this is a functional symptom. If the DMSA score is normal and there is no active significant reflex happening the symptom, then it terminates to a functional dyspepsia. These patients doesn't need any surgical intervention or endoscopic intervention. Mostly they need counseling, repeated psychiatric medications. Those things we can do. So differentiate a patient with a chronic GERD as well as functional dyspepsia. Apart from OGD, the important intervention should be a pH monitoring. Thank you.